One of the joys of EASD TV is that we can bring you special people who have an influence and importance in the field of diabetes, but are not often present at the EASD Congress. And surgeons are a particular example of that. Bariatric surgery is of importance to many people living with diabetes. And to tell us more and to tell us when it's appropriate, whether it's safe, we have Dimitri Pournaras. Dimitri Pournaras, welcome, and thank you so much for making time to come and talk to us. So for lots of diabetologists, bariatric surgery is cloaked in mystery, I think. Would that be a fair thing to say?
I think it's very fair, and I'm usually at the EASD in person, so it is only COVID that prevents me today from being there. But I should point out that it is very often considered something that is different from the conventional treatments for type 2 diabetes and for obesity. However, it is now becoming more mainstream. In fact, for many years now in the annual scientific meeting, there is a lecture or multiple presentations or posters and discussions around bariatric surgery. So I think it's becoming less of a mystery. And we are now appreciating that it is safe. It is as safe as other standard surgical operations would do on people with type 2 diabetes or type 1 diabetes, for that matter, such as a laparoscopic cholecystectomy, a removal of a gallbladder. The risk to someone's life is actually lower with bariatric surgery, looking at data not from clinical trials, but from registries, real-life data, in the UK, in Europe, and elsewhere. So I hope that we're demystifying that.
So it's really important that actually the view that people have of bariatric surgery, which is probably a view based on techniques of, say, a decade ago, are simply not true now because the techniques have advanced so much. As you say, most of it is laparoscopic nowadays.
I would go a step further and I'll say that all bariatric surgery is laparoscopic, and it has been for more than a decade. In fact, the people who have trained my generation of surgeons, so for more than 20 years now, it has been described as conventionally and classically performed laparoscopically. If anything, now we're doing a lot of those surgical procedures using the robot as well. So the standard pathway for these operations is that most of the people who get operated in my hospital after a laparoscopic Roux-en-Y gastric bypass, probably one of the most common operations we do, will go home the next morning. So they stay for 23 hours. And a lot of the data that I see and a lot of the worries around mortality, around complications is from the open era. And that's an era that most of us have not even experienced because that is going well beyond 20 years ago.
Now, what about the impact on diabetes?
It's absolutely fascinating. And in fact, it's one of the reasons that it is the main reason, in fact, is the only reason that attracted me to this specialty many years ago. The impact is phenomenal. So we have seen this, we described this many years ago when people come into surgery with type 2 diabetes and large amounts of insulin and other medications. They can stop some of these medications within days after surgery. And in fact, it has led to the concept of remission of type 2 diabetes, which we're now seeing being explored in other modalities of treatment. So I just want to say that it's not just about remission, but it's about glycemic control. And we do see excellent glycemic control in patients with maximum therapy already. Some of the most challenging patients that our diabetology colleagues see in their clinics with high BMI, with a lot of comorbidities, with high burden of these comorbidities, we do see them getting better, improving the glycemic control, reducing the complication risk from type 2 diabetes, increasing survival, and also at the same time, improving quality of life. Therefore, weight loss is not the main objective. It is what I would say is sometimes a very welcomed side effect. And of course, I'm being flippant about this because it is not truly a side effect. It is a very good outcome. But this is not the main outcome in terms of calculating the benefit of patients who undergo laparoscopic bariatric surgery who have type 2 diabetes.
There's still a lot of prejudice about bariatric surgery. Why do you think that is? I mean, there's a kind of feeling that, it's a last resort, that, it's because patients have not done the right thing. And that prejudice it can really undermine both patients and their professional carers.
I cannot agree more with you. This is absolutely true. And to understand the prejudice against bariatric surgery, we need to understand the stigma against obesity. And that is at the core of it all. So for many individuals, for society, but also for healthcare professionals, there are a lot of us who think that obesity is a lifestyle disease. It is an option that can be treated with a change in lifestyle. We now know that obesity is a disease. We're treating it as a disease. And we also know that for patients who experience stigma, actually the disease is a lot worse. In fact, I would argue that, and we now have the data for this, that it is not obesity that causes stigma, but stigma causes obesity. And of course, this goes into the most successful treatment modality for obesity and type 2 diabetes, bariatric surgery. So for many people around us, it is considered an easy option, a quick fix. It is not. It's quite the opposite. Most of us would not undergo surgery if we can avoid it. For any disease, for any condition, most of us would not have an operation that will have impact in our lives with daily medications for vitamins. All of our patients will be on lifelong vitamin supplementations. They will be on lifelong nutritional blood tests on a yearly basis. So I would really argue that this is not an easy option. It never is. No treatment is an easy option. It is a successful and a safe and effective option. I should point out, though, that it very often is the last resort, and that is because it is often, if not routinely, offered as a last option. If it is offered earlier, we know the results are better. We know we can have a better impact on the beta cell. We can have better diabetes-related outcomes. We can make a bigger difference to our patients. And therefore, we should try to challenge that.
So very quickly, what's the criteria for a patient? What are the things that make a person with diabetes a great candidate for bariatric surgery?
So the criteria by NIH back from the early 1990s, it's the same for NICE in the UK and accepted now globally. It is a BMI for patients with diabetes over 35. For the Caucasian population, we can go down to 30. So 30 to 35, it can be considered when glycemic control is not adequate. And we would go 2.5 points lower for patients of Asian or African origin because the risk is higher. The insulin resistance is a lot more severe at a lower BMI. So that is a lot of people who could benefit.
And finally, a question about medical tourism, because this is an area which is, because people are so desperate that they will go anywhere they can to get it. How should diabetologists advise their patients?
So the easiest answer to address medical tourism is to improve access to bariatric surgery locally. So for every patient who travels somewhere far and is operated in conditions that are not verified, there is an opportunity missed. This could be done locally by the local health service. So I think that's the first thing to do. The second step is to advise patients and understand what their objectives are and make sure that the bariatric multidisciplinary team that is going to look after this particular patient in any part of the world is verified. They know who they are. There are registries now. Now with the internet, nobody is really immune from that. And I would say that, for example, in the UK, we now have personal mortality of individual surgeons in the public domain. So information can be found. And I think that the diabetologist or the primary care physician has an excellent position to be able to advise patients accordingly and definitely stop surgery from happening when it should not be happening.
Dimitri Pournaras, you've been an extraordinary advocate and enthusiast for this bariatric surgery, and it's enormously helpful to have your input, because this is an issue that really does not get the kind of coverage and the take-up that it needs, and we all need to be a lot more active in promoting bariatric surgery, and that's going to take, it's an uphill struggle. So thank you so much for being with us. Well, thank you.
Thank you. Thank you for using.
So a great set of advice and tips there from Dimitri Pournaras. There's more to come.